Hello, everyone, and welcome back. We're going to get started again, and we'll bring Janice Knapp and Anne McLaughlin to the stage here just shortly. I'll do their introductions so that we know who they're speaking, who they are, because they are two other awesome educators. So Janice Knapp has been a diabetes nurse educator in Nova Scotia for over 30 years. She's still very young. She has worked with children, adults, pregnant women, all having diabetes, and she's received several awards nationally from Diabetes Canada for outstanding dedication and outstanding achievement. That was from the CDECB, I believe, and in 2008, she has received an Excellence in Nursing Award from the College of Registered Nurses in Nova Scotia, and in 2015, she was the Canadian Diabetes Association, or Diabetes Canada's, Educator of the Year. So we're very happy to have Janice with us this morning. And I'll introduce Anne as well. She has worked in diabetes care as a dietitian for over 15 years in Nova Scotia's Annapolis Valley. She has contributed to several community initiatives, including food insecurity awareness and screening. Over the past 5 years, she has developed a special interest in obesity in her practice, and she'll be sharing some of that knowledge today. In 2016, she received the Diabetes Care Program of Nova Scotia's Excellence in Innovation Award, as well as the Canadian Diabetes Association Public Service and Education Award. So certainly we welcome both Anne and Janice to the stage, and we'll get them to turn on their microphones and share their slides. And again, reminder to type any questions that you have over in the Q&A box and leave the chat for any technical and other types of questions. We don't see Janice yet. And do you want to take your microphone off of mute? There we go.
For sure. Good morning, everyone. Janice was going to do the start of the presentation. Oh,
there
here
she is.
Okay, I just saw her a minute ago.
Okay, I'll leave you to it.
Thank you, Michelle. Thanks, Anne. Sometimes you could just have to make a grand arrival. Anyway, thank you everybody for taking the time to join us today. I really feel very passionately about this topic. Anne and I are going to talk today about obesity and diabetes care. We're sharing our learning. So the next slide, please. So disclosures, I am now doing a maternity leave with Tandem Diabetes Care. I've also worked with Novo Nordisk last year presenting on obesity, and I've done presentations for LifeScan, Abbott, Medtronic, Omnipod, and Ipsomed, and Anne has no disclosures. Our objectives today, we're going to share the history of obesity management in our diabetes center and to share our obesity learning journey. Next slide. So just to give you a sense of what our diabetes team is and what we're about, we see over 3,000 patients per year. 85% are adults with type 2 diabetes. We see them in individual and in group sessions. And we have partnerships with primary care teams within the community and First Nation communities. Next slide. So we are a rural area. We have a very large service area. It's an aging population, a lot of retired individuals. Our obesity rate is among the highest in Canada, and we do have a lower socioeconomic status. And when we think about this, these people living in a low socioeconomic status, they already have many barriers. And then the fact that they have less coverage for important medications, they have fewer supports, and less access to exercise and resources only increases their barriers. So let's have a poll just to get everybody else's sense. We want you to type in one word to describe a barrier to talking about obesity in your practice. Just one word. Good. Interesting. Good. These are great. Finances, taboo, income, big one. Sensitive, extremely sensitive. Shame, absolutely. Stigma. Yeah, interesting to see what words are common. It is extremely sensitive and obviously a big link to income.
It's really interesting.
Okay, we'll stop that, but that's interesting. Shame, sensitive income.
Thank you.
Thank you very much. Michael Vallis would have a ball with that. So I'm just going to start with the next slide. So years ago, in the early years, and that's, back to the caveman. Next slide, please. When a person would come in my office and they'd say, Janice, I really want to talk about my weight. I want to lose weight. I want to talk about my food. I'd be like, ooh, palpitations. And then I would say, I'm going to get you to see a dietitian, because I never felt comfortable talking about it. And so, but now that's changed, and there's not much back then I would offer to people except to just talk about, well, calories in versus calories out. You have to eat less and move more, all those old lines. And I think about how we're going to learn, and we are learning about how we talk about obesity, is like how years ago when we used to do the diabetes education classes, where I would stand in front of the room, tell them all this wonderful information and just assume they're all going to go home and do it. But I know we've transitioned to more interactive and things like Michael Vallis was talking about this morning, listening to our patients. And I think with obesity, I hope that we're going to transition to a better way of working with our patients around obesity. I often think about a patient I followed for years, and of course there's more than one. And, she was short stature, living with obesity, and all of her siblings were built the same way, and they all had diabetes. We didn't have medications like we do now to offer them, and I don't feel that I supported her the way she should have been. I adjusted her insulin. We talked about blood sugars, but I didn't tell her that genetics play a factor in obesity, and I didn't tell her that it's not your fault. And I hope that going forward, I'm going to do a better job with this. In 2005, we did a project using resistance bands with Jonathan Fowles and Chris Shields. We had videos and handouts to give with easy to do exercises. We started learning about motivational interviewing to assist with this. And instead of telling people to exercise, patients would choose if they were ready to hear it or not. And we based it on the stages of change. We started doing craving change classes in 2012, and this program introduced new approaches to eating behavior and behavior modification. In 2018, Anne here became a certified bariatric educator, and she learned new ways to look at obesity, and we discussed it as a team and changed some of the practices we do in our clinic. Our team also recognized that talking about healthy behaviors and treating obesity improved diabetes outcomes. Now, next slide. In recent years, we started as a team to change the conversation and focus on healthy behavior, not weight. We focus on exercise for its healthy benefits, not for weight loss. We talk about small, attainable goals, decreasing our sedentary time. We discuss that genetics is a risk factor that we can't change. We discuss sleep and its effect on our eating, knowing that the less sleep we get, the more we crave unhealthy food. And I'm sure we see that in our own lives. In 2018, I heard Dr. Sean Wharton speak at the Diabetes Canada conference in Halifax. And he said, it's not their fault. And that was a real changing point for me. I was very embarrassed and knew that I had to change my practice because it isn't their fault. And it's really changed my outlook on how I work with persons living with obesity. After the conference, as a team, we discussed what changes we could make as a team. What could we do in our center? And I think back to a man that we saw, and he was in his late 20s. He came to our newly diagnosed class, and he was over 400 pounds. And of course, the first thing we did back then, when people come to our class, here, step on the scales. Hello, my name is Janice, and I'm going to weigh you. And doesn't that make you want to walk back out the door? And, then he came and sat in a class full of people. We had plastic chairs. He sat in them and they curved up in the sides, and sure they dug into him through the whole class. And I was worried through the whole class the chair was going to break. I'm sure he was worried about that too. And you know what? I know we made him so embarrassed and uncomfortable. And needless to say, he never came back to our clinic, and I don't blame him. We did a terrible job. But now in our diabetes centers, we have bariatric chairs in our classroom and in all of our offices. And when patients come to our clinic, they're not weighed. It's an option at the end of the appointment. It's their choice if they want to get weighed. Our patients need to feel safe and not embarrassed when they meet with their healthcare provider. Anne?
My journey is a little bit different. I have relatives and friends living with obesity, and I've watched my relatives on various diets over the years with weight loss and regain, and also the pressure that they put on themselves. As a result, I began my interest in obesity early on. It just took some time to make the change, and I very much describe it as a journey, and I'm still very much on that journey. I think back to the earlier years in my practice, and I have a similar story to Janice, actually, in terms of feeling that I wasn't supporting my patients as well as I could. So I would follow them regularly, and we would weigh them. Sometimes it was one of the first things that we did. We talk about food and exercise, and we talk about strategies too, but it was very much about portions and exercise and amount, and it was goal setting, but it was more of a focus on what and how much and less on the reasons of why and the background. I also had a negative encounter with a patient regarding weight in a routine diabetes visit, and that was a changing moment for me as well. I also remember another patient who wanted to lose weight, and they were always positive visits. She would come in, and sometimes she would journal, and we'd talk about snacking and healthy snacks, but she was really hard on herself and kept coming back to her weight and was focused on that number. And then at one point I decided, let's shift our focus, and we took the focus off of her weight and on the positive behaviors. And it ended up that she was happier that way, and it was preventing further weight gain rather than loss with her. And so that was really impactful for me as well. In 2012, things also started to change for me when I attended an obesity conference. There were many aha moments for me then. One of them was that my oversimplistic messaging of eat less and my exercise messages around move more. But also I realized the exercise recommendations I was making were not necessarily appropriate. So for example, swimming. So there were many barriers to swimming for my patients that I didn't realize at the time. So the access to the pool, for instance, so steps versus ladders, but also the locker room. So access in the locker room, safety for changing, space, and comfort as well. At that conference, I also learned about mental health and the connection as well. And I was working a bit with this population at the time as well. So this, again, continued on my learning journey and made me want to learn more. Around the same time, Craving Change started in our center, and that was really great because we were talking about food differently. So we were talking about the environment, and we were talking more about the why, and we were also helping patients with strategies to help rather than just focusing on portions. And for me, facilitating that class, I learned so much from the patient conversations, and I continued looking for resources and more education opportunities. So at that point, we were in Craving Change talking about stress as well as strategies like distraction and asserting yourself, for instance. And I also started changing the questions I asked and stepped away from the usual questions that I would ask and began learning some things along the way. And that was also at a time that we were learning new skills around motivational interviewing. One thing I will say is that it's very much still a learning journey. We're still very much learning, and there's still new information and resources all the time. And a big part of this is sharing our practices. And I think I noted in the word cloud comfort, and I do think that that comes with talking about it and sharing learning as well. Next slide.
So why do we need to talk about that? What's the potential impact of obesity interventions? So when we look at the impact of obesity interventions, we know from our clinical practice guidelines that 5 to 10% of weight loss can improve health and wellness outcomes. But just telling people does not make it happen, as we know. We need to discuss best weight, which could mean weight stability and preventing weight gain. So best weight is the weight that the individual maintains at when they're doing the healthy behaviors they feel they can do for the long term. So what healthy behaviors can your patient maintain in their life to prevent weight gain and possibly even weight loss? So even if they keep this weight off for a few years, it may delay the onset of diabetes or other chronic health conditions or risk factors and improve quality of life. In diabetes care, we can sometimes be so glucose focused that we do not talk about weight or behaviors leading to weight gain. What if we, the healthcare system, intervened sooner? Obesity is often not discussed until there's a health issue. Should we see them sooner? Have we considered obesity clinics? We, the healthcare system, we need to talk about this sooner so that we can prevent or delay obesity. Just think of the money we would save doing that in healthcare. We need to celebrate successes big and small. We need to redefine success, but not by the pound. Next slide.
So changing the conversation has been really important in my practice, and talking about obesity as a chronic disease and that it's not the patient's fault. And that's a big part of the conversation, both in group and on an individual level and with other providers. So obesity is a chronic disease and it requires long-term treatment and support. So we want to give the patient the tools to manage lifelong and explore all the factors influencing their weight and treatment options. So it's about improving their health and not the number on the scale. So taking the focus off of the weight and onto the behavior. And I noted in the chat as well about the weight and when you weigh, and I try to weigh at the end as well. So it can be challenging to talk about weight, and I find sometimes patients still want to set a number, and I really try to move away from that and talk about a behavior-shaped goal. And I find that when you do that, it also becomes more positive. So let's reframe and talk about how we can improve our health. For example, adding a vegetable to our lunch. Sometimes this can be challenging because that was the past with some of our patients, and they were very, very focused on that as well. And it's not their fault. So there's a lot of blame and shame, and past experiences and the media have a part of that. So people tend to think, you know, willpower and why can't I lose my weight and keep it off? I had a patient ask me that the other day. And so it's really important to talk about the science behind obesity and look also at the root causes and explain to your patients about obesity and the role of the brain and our hormones that are involved. There's no one-size-fits-all approach, and we want to be mindful of that. So a client-centered approach, and you really want to understand the lived experience of the person with obesity. So look at the many factors that are affecting their health, and options would include different dietary patterns. Look at movement and sedentary time and sleep, stress, and medications as well. We have discussions about mindful eating, hunger and fullness and cravings, and we explore food insecurity, the eating environment, the relationship with food as well. And we want to make sure that our nutrition advice are things that will work for the patient and match their values, preferences as well. Another part of this is in our groups. So in the past, sometimes when weight came up in the group, the conversation was maybe, the conversation looked different. Now it's about similar to what I just said. So talking about the science behind obesity and that it's very individual, that it's more than just willpower and the challenges that are involved, and that it's different for different people. And I think that's an important part as well, is educating the public on that as well. And also students and other health professionals. So now when we have dietetic interns, we really try to talk about obesity. I have them read the bias chapter in the practice guidelines, and it's definitely a part of conversation. And we've also really tried in education events to have a topic such as obesity on our agenda quite often as well. So next, I am going to introduce our case study. So Janice is going to walk you through a case study to show our changed approach. Next slide, please, Christian.
So the case studies that I'm going to be talking about are patients that we've seen in our clinic, and of course we've changed their names and their identity to protect them. So I'm going to introduce Mary. Mary's a 38-year-old married woman with 2 young adult children who live at home with her. She has type 2 diabetes. She's on metformin. A1C is 7. Blood pressure is normal. Weight's 325 pounds. And she was seen in Emerge complaining of a sore back. So Mary then was referred to us from Emerge, and we've been following Mary for a little over a year now. When she came to us, she was angry and frustrated by her experience in Emerge. The doc told her the reason for your sore back is that, in quotes, you are fat and you need to lose weight. I asked Mary to tell me her story. Mary said after her first pregnancy, she started gaining weight, and she's been gaining weight ever since. She's on social assistance, She cannot afford sneakers. So when people say go walk, she doesn't have any sneakers. But I told her, Mary, you have a chronic disease. You have a real medical condition. Next slide. So I said, Mary, just tell me what your healthy self looks like. And she said, I would like to have more energy. I want to feel better physically, and I want to improve my blood sugars to achieve my best weight. So then I asked, what are you ready to change to reach that vision of your healthy self? And she says, I will try to walk more often and buy new sneakers, and I will start a new GLP-1 that the medication's been asking her to try for a while. And recently in Nova Scotia, GLP-1 Ozempic was recently covered, and that's made a big difference in our practice. So next slide. So what's going well for Mary? Right now, her weight gain has stopped. She was able to afford, she budgeted over a couple of months, and she was able to get her sneakers. She's walking 20 minutes, 4 to 5 times a week, and it feels good. And now it's part of her routine, and it gets her out of the house. She's very curious and engaged. This was the most surprising. She's reading more. She's attending her appointments virtually, and she asks lots of questions. So there are long appointments because she has so many questions, but she's really engaged. But what's getting in her way? Getting out for her walk can be difficult at times because of her sore back. And the other is family food preferences. Having to eat different than everyone else is really hard. So we're trying to help Mary manage better in the environment she's living in, how to handle situations when fast food and other snack choices are around, and we're problem solving and troubleshooting together. Again, the solutions that come from Mary are the ones that are going to work. What to do when she's feeling down? We use positive self-talk to remove shame and blame. Your condition is real. You just have to keep reminding her. Next slide. Now I'm going to introduce Jim. And Jim is a 56-year-old truck driver who works long hours, and he says he has no time to exercise. His A1C is climbing now. It's 8.9. He weighs 275 pounds. Jim's on metformin and glycoside, and he does not have private health coverage. He refuses to start insulin because he wants to drive his truck in the States. And a lot of times, although I hear this could be changing, that if you're on insulin, you're not allowed to truck into the States because of an accident that happened years and years ago, and they changed the law. So next slide. So we met with Jim, and after a couple of visits, Jim agreed to start a GLP-1, which is now covered under our provincial program. And he agreed to walk around his truck 4 times when he stops, because truckers usually have to walk around once just to make sure everything's looking okay, but he does it 4 times just to give some extra movement in there. He said it's possible to pack some of his own food for snacks when he's on the road, but he plans to eat his meals at truck stops. He likes that social interaction and getting out of his truck. He sleeps 5 to 6 hours a night, and he sleeps at various times. He does not think he can change this. So in this case, we have to remember that we have to kind of meet Jim where he's at. This is what Jim has agreed to do. It may not be my goal, but these are his goals. And these are positive changes. These are healthy behaviors. He's going to walk more. He's going to try to eat snacks that are a little healthier. He can't change his sleep, and he can take a GLP-1. So we have to meet the patient where they're at. And a success is a healthy change. So there's a couple of successes in there. So we have to celebrate those. And Jim actually is preventing weight gain, and he's doing what he can with the lifestyle that he lives in. Next slide. So just advance that a bit more, Christian. Thank you. So when we're addressing obesity and diabetes, how do we support our patients? So what we've done in our center is lunch and learn opportunities. All right, so we have make sure we ourselves are better informed so we can help our patients. Okay, so just like we tell our patients they need to learn more about their diabetes, we need to learn more about obesity. Okay, and so maybe that's through lunch and learns, maybe that's through conferences like today. So whatever opportunities we can do, they're very important. We need to tell our patients it's not your fault. There are things that you cannot help, and they need to hear that. Our brains, all of our brains have had 1 million years of evolution trying to get us back to our highest weight. That's why people regain their weight loss, because that's what our brain is trying to do. So we also have medications out there And we have, make sure we take advantage of the ones that they have coverage for. If they have private coverage, they have even more options. But use the medications that can help with weight loss. That's so important. Ask permission to talk about weight and listen to their story. It's not more work to do it right. We have to share learnings with our colleagues at staff meetings, workshops like today. It doesn't have to be a big deal. We need to self-reflect on our own work and see what has worked and what has not, and just keep reinventing and share that with your coworkers. Next slide.
So a few practice pearls. So when we talk about healthy behaviors, as we mentioned, we want to look at the big picture. So it's for health, not weight. And we want to focus on the behaviors. So sleep is a part of that. So we talk about sleep. We talk about sleep hygiene. We've learned as a team about sleep apnea. Exercise, so exploring options. Consider the patient needs. So maybe it's resistance bands, maybe it's chair yoga, breaking up the sedentary time. There's so many options. Just remember that there may be barriers, and to try to talk through that with your patients. Nutrition. So remembering that there's different dietary approaches or patterns. We want to explore the relationship with food. So who do you eat with? What are your thoughts about food? What time of the day is your hunger the highest, as an example? And we want our nutrition messages and recommendations to meet the values and preferences of our patients. And remember that we want to choose an eating pattern that supports their best health and in the long term. Promoting behavior change support, so motivational interviewing, goal setting, problem solving, and looking deeper at the barriers is a really big part of that. I think my exercise example really brings that home. Assisting with the patient with change that's meaningful for them, and making sure that it aligns with their values. As well, we want to listen to their story. So Janice mentioned that, and that's been really impactful for me, and you learn so much. I know that came up in Dr. Vallis's presentation as well. And so you really, I've learned a lot by listening. I had this one patient, and she came in, and I asked her to tell me her story and tell me why she was in our office. And she sat and she just started talking, and I found out a lot about her diabetes and a lot about her weight and a lot about her food. And at the end, she thanked me for that. And we did talk about food in the end, but it was just a different dynamic and a way that the way that we talked, and it was really impactful. So the 5 A's, so ask permission to discuss weight. Don't assume that everyone wants to talk about their weight. And if they're not ready, then that's okay. And you can extend the option to talk about it in the future. We want to assess and understand their story and look deeper at the barriers and factors affecting their weight. Advise on medical nutrition therapy, for instance. Agree on a plan, so goal setting and building in those barriers and problem solving. And assist, so offering education, resources, referrals, and follow-up. For me, mental health is a part of this as well. And so eating means so many things to people, and so we want to talk about mental health and the impact of eating for reasons other than hunger, and our coping mechanisms around our food, and discuss reasons for eating. And distraction is a strategy that we talk about sometimes as well. Stress management is a part of this, so stress and coping. So we talk about stress and coping with our patients, and talk about relaxation techniques. Language. So remember that it's a person with obesity, not an obese patient. We want person-centered language, and your language really does matter, and you want to try to use positive language and promote that with other health professionals as well. And we want to be collaborative and empower our patients. Something else I learned along the way is to say, rather than you, some people find it easier, or some people find it helpful. Remember bias as well when you discuss weight, because our patients sometimes do have a lot of blame and shame, and also think that it's about willpower. And remember that they may have experiences in the past as well, so it's important to try to understand that as well. And we need to be open to change and accepting of various approaches as well. Consider the environment. And so in our diabetes center, that's been a big part of that as well. So we've moved the location of our scale. We want to weigh our patients in private, but consider the location of your offices, the setup of your office, bariatric chairs, as Janice has mentioned, in all of our offices and our waiting room. Consider kind of accessibility from a wheelchair standpoint and accessibility with doors. Locate and also asking about the scale and when. And do they want to be weighed? And we've already mentioned this, but not weighing initially at the beginning of the visit and leaving that up to the patient as well. And as we've already said, talking about it as a team and continuing to learn has been really impactful in our practice. Next slide. So here are some resources. So Obesity Canada is a great resource and there's lots of information there. So the main page, the website, as well as the 5 A's, there's a good document on language. And then there's also a quick guide as well. And so I encourage everyone to take advantage of those. There's a lot of really good webinars that have been produced by Obesity Canada recently, and they have been they've been great. And then lastly, we participated in the Novo Nordisk learning modules, mostly virtually. So the Obesity Care Toolkit, and there are some great resources there as well. Next slide.
So we're going to have a poll. Let's have a post a little poll. If people want to. So it's coming. So what is one action? It's going to come up. We want to know one action that you can take back to your practice. Self-reflection, seek out more learning about obesity medications, learning about whatever you just click on, they're moving around. Okay, I think that's good. Let's have a look at that. So people are asking permission to talk about weight. That's awesome. And seeking out more learning about obesity, self-reflection. These are all really good. Learning about obesity medications. And, so there's lots of things that we can learn. And there's probably there's definitely things on the list that we didn't post. But I think asking permission is always the first step. So next slide. Is we just want to say thank you. I appreciate everybody attending today. And I think we have some questions. If anybody has further questions we don't get to, feel free to let us know, but there are some questions here. So.
Thank you. Thank you again, ladies. What a wonderful presentation and very refreshing to hear conversations that we really need to bring to the forefront in our practices as well. So I can go through the questions for you if you'd like, or are you guys okay to read them yourselves?
I can see them myself.
Grand. I will leave you to it.
I'm on fire today, Michelle.
Oh, you are.
So Anne, do you want to take the first one? Yeah.
Sure. I'm not sure that I'm seeing the first one.
Okay, any advice for counseling clients who have been given inappropriate nutrition advice by their doctors, such as severe caloric restriction?
That's a good one. And I guess I would say it's very individualized. I would talk to the patient about what their needs are and what's going to work for them. And again, it comes back to what's sustainable as well and what's going to work for their patients, and considering that there are many barriers they might have, as well as, for instance, financial. So I think it's really important to kind of look at the individual and their needs and capacity, and also consistent messaging. So back to the physician as well. And
can I add to that, Anne? I always think of Dr. Vallis this morning with his advice, saying, your doctor has said this, and he cares about you. This is what he feels is important. This is my thoughts on it. I think, this is what, and I think this is, you have to find something you're going to maintain, not something you can do for a month, and kind of angle it that way. And I think that might help the patient to feel they have more choice, that they're not having to pick in between.
Agreed. And also going back to kind of what happens in terms of weight and the science of obesity and explaining that to the patient as well, and that what you do is something that you need to do in the long term as well. Yeah.
Because that's a very common occurrence. So, yeah. So the second one, should we weigh at each visit?
So individual as well, right? So sometimes it can be really negative and too focused on behavior. So I really think ask the patient, and it's what they want and what's going to be most helpful for them. So yeah, it's individual, and no, I don't always weigh at each visit. I take the weight off sometimes.
I know the answer to the next one. Would love to know who's on your team.
And
so Anne and myself, Lisa DeMolitor, who's speaking next, Heather Angel, and Shauna Boudreau. Those are the people on our team. We have a really great team that we love to, we learn a lot from each other. And we're all who we are because
mix of professions.
Nurses and dietitians.
Yeah. And I would say that we learn a lot from each other, and we challenge each other, and sharing is a part of that. So, you know, if we're sharing a story, or we seek opportunities to ask questions and get their thought. And I think that's been a great learning as well for us. And also our outpatient dietitian is located close to us as well, Kendra Riggs, and she's been a part of that as well.
Yeah.
And we are from, I'm just seeing the bottom here. So we are from Kentville, Nova Scotia in the Annapolis Valley.
A small town, rural hospital with a big heart. So the next question was, how can we, no, there was one about, this one's for Anne. I'm curious if you screen for adverse childhood experiences, trauma, and if your practice setting approach is trauma informed.
So we do not screen per se. It would be what would come from the referral or in talking with the patient. If something came up in practice, we would definitely speak with the physician or refer back to mental health and use, we have other avenues in terms of mental health supports needed as well. Did you have something to add, Anne?
No, I think we do, like when we are, like for adults, that's part of the listening. So when we get them to tell their story, lots of times that would come out. You know, I had, anorexia when I was in my teen years or things like that. So that's why the listening and take that, tell me a little bit about yourself. I'm just getting to know you. And lots of times that comes out. So get them to tell their story. Now, the other question is, how can we support clients and foster confidence, raising concerns such as when patients are raising these issues and their goals or behavioral changes and primary doctor suggests bariatric surgery? Boy, that's a full question.
It is a full question. So I think it comes back to, again, a conversation with our patient and finding out what their desires are and working with them and being an advocate for them as well and a support to them to meet their needs. So in terms of communication with the doctor and making sure it aligns with the discussion that you've had with the physician or with the patient, and follow up with the physician as well, if needed. And I think educating the patients on the options for them so that they have kind of the up-to-date knowledge as well. We've also given them reading materials as well. So reading materials for them to review would be another one. Bariatric surgery is,
go ahead.
Say that? So that's a whole other question. So within our team locally, we're actually learning about bariatric surgery, and so as a team, that's a new learning for us. It's something that we haven't been involved with before, but there's some interest locally by a physician. And so we've met with the physician and we're together learning about bariatric surgery and the options in our province for our patients. And some of us have started a little bit of education on that as well.
And the education they're doing is how to prepare a patient for bariatric surgery, because there are things the patients have to have accomplished before they're eligible for bariatric surgery. So that's where their learning has come in. So, and then there's another question that somebody had brought up, that do you have an approach with kids when you have mom or dad with them at the visit? So I'm going to start this because this happens frequently because we do pediatrics as well at our center. And oftentimes, just like you're saying, the child's in the room, and she's fat she's fat. You need to tell her to stop eating so much because she's fat. Just look at her. So that's where the education, and we have to do it in front of the parents to say, this is not healthy conversation. And I'm going to let Anne take it from here.
I was just going to say, so yes, we would stop the conversation and frame it more positive. And then again, that's where we would get into the specifics around moderation and balance and positive eating behaviors, eating together as a family as a part of that as well. So we would try to stop the conversation, and then I sometimes, and obviously address the conversation, but then I will also pull the parent out, or one of us pull the child out, and then we'll have a more of a conversation around that and the impact of that. And I've also had conversations afterwards as well over the phone. And then trying to navigating that conversation can be a challenge for sure.
It is. It's a tough one. And that's why sometimes, like Anne said, the phone call after might be, but it's hard to change personalities. Sometimes it means you pull the kid in privately and just say, you know what, it sounds like you're doing lots of healthy things, and that's what we want you to focus on. So last question here. How do you deal with the clients who are doing online diet of the week, and because they are losing weight, they see success, but don't see the risks?
So I think it's, again, a conversation and helping them to identify the risks. So it's always our job, I think, to educate the patient on the risks, and it's their choice ultimately. But it would be a conversation around the safety, and then presenting kind of the data around long-term weight and obesity and the science of obesity, and what to do needs to be something that you can continue on. So you always kind of come at it from the safety lens, and what can you continue with in the future, and talking about the science behind it.
I just want to thank everybody for letting us share our journey. We're not perfect. We're trying our best, and we're learning from our mistakes and learning from our successes. So good luck to everybody.
Thank you so much.
Yeah.
Thank you. Okay, Janice and Anne, you can turn your cameras and microphones off. And we're going to invite for our next speaker, right on time, Lisa Demolitor. She'll be sharing with us some great technology things this morning. So we're excited for that, because we are in the age of that, especially now that we are more virtual and technologically savvy. Lisa has spent most of her career in the Kootenays in British Columbia, and she's returned to her maritime roots and now lives down in the Annapolis Valley, as Janice and Anne had mentioned. She attended Acadia University, yay Acadia, for a Bachelor of Science, and Waterloo for her Master's in Public Health. She does love thinking about food, talking about food, and eating food. I mean, who doesn't really? And Lisa has a special interest in diabetes technology, and of course always learning and troubleshooting. So we welcome Lisa to the stage today, and I'll pass it over to her. A reminder for folks to put your questions in the Q&A tab over on your right-hand side, so we can get those questions answered at the end.
Thanks, Michelle. Hopefully you can hear me okay. So the objectives for today are to do a basic review of the standalone sensor technology, discuss the guidelines and resources that are out there. Oops, I just advanced my slide. Not supposed to do that. And I also want to look at the various reports and the elements of those reports, consider strategies that can help with diabetes management, and appreciate the burden of diabetes and diabetes technologies in people living with diabetes. So we see here 4 red dots that represent fingerstick glucose levels. Each of these are in target range, but we can also see that there's a glucose sensor line showing the times of highs and lows, including nocturnal lows that are often missed by fingersticks. So according to the ADA 2021 standards of care, most people using intensive insulin regimes should be encouraged to check their BG prior to meals and snacks, at bedtime, occasionally after meals, prior to exercise, when they suspect a low BG, after treating low BG, until BGs normalize, and prior to and while performing critical tasks such as driving. So this ends up being a lot of checks per day, and certainly a huge burden if you're doing finger sticks. So the picture on the left here shows the anatomy and the environment in which sensors work. So you see here that there's a filament labeled here as a sensor, and it sits in the interstitial fluid. The filament is covered with enzymes that react with the glucose in the interstitial fluid, and this chemical reaction is then translated to an electronic message. This message is held as data in hardware, and I'm using the word hardware here to be inclusive, because technically the Freestyle Libre doesn't have a transmitter, but it does have a little component that will store data and transfer it to a scanner of some kind. So the picture on the top right represents flash glucose monitoring, or FGM, and the Libre would fall into this category. These sensors do need to be scanned to see and collect the data. The picture in the bottom right represents the real-time, or RT-CGM, and these systems have a transmitter that will continuously send data to a device. These devices have a variety of alarms that can help notify the user that certain limits have been or will be reached. And the Guardian Connect from Medtronic and the Dexcom G6 do fall into this category. Regardless of the sensor, all of the sensors provide the game-changing benefit of the rate of change arrows, and we're going to talk about these later, but they certainly provide valuable insight. So I've talked that the sensor is reading interstitial glucose, and it's not blood glucose. So while interstitial glucose correlates quite well with plasma glucose, it can at times lag if the glucose levels are rising or falling rapidly. And this is really well represented with this train analogy. So the front of the train corresponds with the blood glucose, whereas represents the sensor glucose. In times where the rate of change is rapid, the difference between the two will be more pronounced. And in times where BG is more stable, the difference will be little or none. And of course, the technology, as it improves and improves, the lag time becomes less and less. We know that an A1C of 7% can have many background stories. The time in range has the benefit of showing variation within the day and from day to day. This rich data offers opportunities to analyze data at levels that were never before possible. And for some, this intensity may help improve glycemic control, but maybe more importantly, from the angle of SMART goal setting and self-motivation, compared to A1C, time in range also provides faster feedback, and feedback that rests in the hands of people living with diabetes instead of A1C, or lab measures that are held and delivered by healthcare professionals. Another great benefit of time in range isn't subject to the same factors that can confound A1C. So conditions such as anemia, hemoglobin disorders, iron deficiency, and pregnancy may skew A1C values, but they do not affect time in range. To put time in range values into perspective, a time in range of 70%, so 70, corresponds with an A1C of 7%. A time in range of 50% corresponds with an A1C of 8%. And another way to think about it is that for every 10% time in range change, there's a 0.8% change in A1C. So in 2019, there's consensus recommendations published for sensor data utilization and reporting among various diabetes populations. So we see here the various time in range and parameters recommendations. So on the far left, we see adults, and the glucose parameters here are 3.9 to 10 millimoles per liter. The time in range target is 70% or greater. The time below range is 5% or less. Within this, you're going to see level 1 and level 2 hyper and hyperglycemia with the yellow and the orange sections and the red and the darker red sections. Next over is the older or higher risk adult, and the parameters here are the same, 3.9 to 10 millimoles per liter, but the tolerance for time below range is less, at less than 1%. Time in range goal for the older adults or frail elderly is 50% or greater, which corresponds with an A1C goal of 8% or less. And this is consistent with our Diabetes Canada CPGs. The third one there is pregnancy parameters, and these are different. So 3.5 to 7.8 millimoles per liter. The targets for time in range for GDM and type 2 diabetes are not included because more research is needed, but a good thing to keep in mind is that during pregnancy, the goal is to safely increase time in range as quickly as possible while reducing time above range and glycemic variability. Now, there are some standardized reports that don't allow for these target parameters, the 3.5 to 7.8%. It doesn't allow the targets to be changed on the reports, but we're going to discuss this. You'll notice that children are not represented in these charts, but when you look at the footnote on the bottom of this figure in the original report, we see that the time in range goal for children is 60% or greater, which corresponds with the Diabetes Canada and ADA A1C targets of less than 7.5%. And remember, these are just goals. If you meet somebody for the first time and they're not meeting these goals, don't let that be discouraging for them. The goal is just to work towards the best that we can achieve. Another tidbit to keep in mind is that for each 1% of time in range, it equals about 15 minutes of the day. So when you think about it this way, when we look at the adult's target of time below range of 5% or less, this equals a time of 1 hour and 15 minutes or less. So interesting to think about that way. Apps may not be something that some of you deal with in clinic, but I find that I'm perusing a lot of app stores these days. I just wanted to show these images so that you can see what they look like. On the far left, you see the Medtronic Guardian Connect. Then you see the Clarity and Dexcom apps and the Freestyle Libre on the right. And each of these have some type of companion app or program that will allow loved ones to follow the sensor data live, which is very helpful. All right, so this is just a little chart that I've put together to help me organize my thoughts to compare the different options out there. So age indications are changing as technology advances. It is hard to keep track, but these are the most recent age indications. For data visibility, with the CGM or the real-time CGM devices, data is continuously visible and always pushed towards the device. With flash glucose monitoring, the user does need to scan to see and store the data. Treatment decisions. So some systems require SMBG for making treatment decisions, and these are called adjunctive devices. Devices that do not require SMBG confirmation are called non-adjunctive. So even if some sensors are labeled as non-adjunctive, they may still require fingerstick verifications when systems or symptoms do not match the sensor glucose to verify lows, or if the blood glucose is rapidly changing. And you all want to check with the product manual for brand-specific advice on this. Alerts. BG alerts are a great safety feature, one that's super helpful for parents, folks who are really active, people with hypo unawareness, people with fear of hypos. Real-time CGM devices do have customizable alerts and alarms, and they also have predictive alerts. So alerts that will alarm before the person reaches a low, and this can range between 30 minutes or 60 minutes. The Libre 1 doesn't have alerts or alarms, but the Libre 2 will have 3 optional alarms, and that's low BG, high BG, and signal loss. It, however, will not have the predictive alerts that the real-time CGMs have. Warm-up period. The warm-up period is just the period of time after a sensor is activated, so not inserted, but activated, that it will provide data, and this can range between display options. The Dexcom is compatible with smartphones or smartwatches, and they also have a standalone receiver if smartphones or smart devices aren't an option, so maybe young kids who don't have cell phones. The Guardian Connect uses iOS devices or Apple products. The Libre can be used with a Libre meter reader or a smartphone that has near-field communication. Substances that can interact with sensors certainly vary depending on brand. So just look at the chart for the specific substances, but we know that hydroxyurea, acetaminophen, and vitamin C may elevate sensor readings falsely, and aspirin can falsely decrease sensor results. We know that education and support for people wearing these devices are integral parts of success in sensor technology. Setting expectations is part of this good education and setup. So talking about calibrations is important. Calibrations aren't required of all sensors, but if they are required, it is important to discuss the best way to manage or schedule these for the best accuracy and the best schedule and timing of the alarms or reminders. Calibrations need to happen when BG are most stable. So this usually means calibrating before meals and before bed to avoid interruptions or alarms in the middle of the night. And lag time. There has to be an element of trust with sensors, and this can be impacted if lag time isn't discussed. Moreover, the safety aspects of lag time during hypoglycemia should also be touched on, as finger sticks may be required in situations of hypoglycemia. Alarms, we've talked about alarms, and we know that they can be handy, but of course everyone is different. So for most folks starting with sensor technology, it probably is best to go with the bare bones alarms. This means probably turning off most alarms and just setting those predictive low or the low alerts for safety. And the same is true of targets. So if we set too many alarms, or if the targets are set too tight in the beginning, the person may experience alarm fatigue, which could impact their relationship with their sensor, or maybe even their ability to use one. This is our poll. So when you go on the Facebook sites for people wearing sensor technology, what is a common term that's used? So this is kind of just a fun one. So I don't know if the Slido poll could be put up. And so the different options here are unicorn, marinate, jig, bleeder, and flicked. So which one is a common term that's used? I don't know if the poll is going. I can't quite see it. I mean, if the poll doesn't come up, we can also just throw stuff in the chat box of which term you think is not a common. So most of these are, and so we can just look at those. Any chat box or, oh, the link to the poll is put in the chat box. That's okay. We don't have to do the Slido poll. For the interest of time, we can just throw some ideas in the chat box. Oh, there's the poll. Ah, I love polls. So which is not a common term? So bleeder seems to be on the headboard there. All right. Cool. What a distribution. Okay, we'll go back to the PowerPoint if that's okay. Perfect. So I'll just go through these. So a unicorn is often seen in the US groups, and it could mean a sensor reading of an even 100 milligrams per deciliter. In Canada, this translates to a reading of 5.5. I've also seen a unicorn referred to as a time in range of 100%, but that's certainly more rare. Marinate is the act of inserting a sensor for a period of time before activating it. So this allows the filament and its enzymes to marinate in the interstitial fluid. And for some, this can mean better accuracy when starting a sensor, because some find that sensor accuracy isn't as good in the first day of wear. Jig is a term that's not often used, and it's funny because in the poll, that was one that not a lot of people picked. Bleeder. So when there is bleeding at the sensor site, blood may not always be able to be cleared, and you definitely want to refer to the manufacturer's user guide about the situation to determine next steps, because it's really important not to get fluid or blood into the unsealed innards of the transmitter. So the saying on the groups is bleeders or readers, and some people enthusiastically identify with this and others deny it's true. Flicked is when a sensor is unceremoniously plucked, pulled, or torn. So I mentioned the 2019 consensus guidelines, and in these guidelines, there are 10 core metrics for assessing CGM data. And I'm going to link these guidelines at the end, so don't feel that you have to write them down now. And as a disclaimer, I've tried to juggle being equitable in visually representing each of the company's reports while still finding relevant examples. So this is an AGP report for LibreView, and the first thing that I look at is evidence of adequate data. So the orange square here shows that this report is based on 14 days and 97% sensor time is active. And the goal in the consensus report is to ensure that you have 14 days and at least 70% of active sensor time. In the middle of the screen is a little blue box, and this represents the variability of glucose in terms of percent coefficient of variation. And the goal in the consensus guidelines is to have less than 36%. The colorful vertical bar kind of on the side here represents the time above range, time in range, and time below range. And you can see here, as we mentioned before, there's the level 2 and level 1 hyper and hypoglycemia shown in the yellow and orange, and then the red and the dark red. And we've already discussed the parameters or the targets for various populations In the case of this particular AGP report, if you have somebody who's pregnant, if they set specific pregnancy parameters in their device, they will not show up here. You're still going to see the parameters of 3.9 to 10%, and this is just for standardized comparison. And we're gonna talk about how to do those individualized reports in a bit. This is a Dexcom report, and so we see in the green box range data, but you see in the yellow here that these percentages don't actually add up to 100%. And this is because the time in level 2 hypo and hyperglycemia are actually additional descriptors instead of part of the full 100%. And this threw me off at first. So just pay attention to that before you document, because it'll look a little funny otherwise. So when you look at the AGP graph, I also call it the 24-hour river. A lot of you are going to be already familiar with this, but there's a line, an orange line in the middle of the river, which represents the median glucose throughout the day. The shape of this shows the daily patterns in glucose, and you want to see what it looks like. So does it look like sharp mountain peaks or gentle rolling molehills? And you also want to see if the median line is within range. So the range here, 3.9 to 10% is the gray hashing. The blue band is the 25th and the 75th percentiles, and this is where most glucose values lie. The width of this band shows the variability in the glucose data. So the wider the river, the more variable the glucose, and the dotted lines or the dashed green lines are the 10th and the 90th percentiles. And the first thing that I look at when I'm looking at this river are there any times in the day where the river dips below 3.9? So if the hashing or if the dashed lines dips below, or if the blue band dips below, that will tell you how much hypoglycemia there is. And also, is there a significant amount of times where the band is going above target range there? This is a report from the Medtronic Guardian Connect. It has the same information that we previously discussed in the other reports, and it looks a lot like the other Medtronic reports that you may be used to. If tracked, insulin doses and carb information can also be seen in these statistics, and you can see yellow square there that the settings are there. So this is good information to look at if you're wanting to look at alarms and see if they're realistic and manageable. This is a snapshot report from the review, and the reason why I included this report is that, as mentioned before, the AGP report have hardwired standardized parameters, and for Libre, if somebody is pregnant and they set individualized parameters, they're going to show up in this snapshot report. And so if you want time and range for pregnancy, this is where you're going to look. So you can see here in the pink box that these targets of 4.1 and 9.9 are individual targets that this person set, which for the record, these aren't based on any recommendations. It's just the random targets that the person has put in. But I also like this report because it has a great visual for episodes of hypoglycemia, the pink graph down there, and it's really powerful when you're wanting to look at patterns. So you see a really strong pattern here of nocturnal hypoglycemia, but also hypoglycemia around noontime. Once you've looked at the 10 core metrics on the AGP report, you may be ready to dig a little bit deeper. If you're not already familiar with Adam Brown, checking out his works on diatribe.org is really useful. He also wrote a book called Bright Spots and Landmines, and he also prepared a great report that you can see here, 42 factors that affect blood glucose, and it's a really colorful and thoughtful paper that reviews the multitude of factors that can affect BG, and it's a really nice discussion tool to have on your desk because it provides a manageable framework for troubleshooting with patients. Talking about digging deeper, mealtime reports such as this one can be really handy at carbohydrate ratios and correction factors. They provide information on pre and post meal readings, carbohydrates, and insulin. And some even show kind of a day-to-day breakdown on each decision. So what blood glucose was before the meal, after the meal, how many carbs, how much insulin, that type of thing. So a great way to kind of look at mealtime buckets and patterns. This is an example of daily reports, and daily reports can look at each individual day for a really deep dive. These reports have a lot of information and they can be very useful when assessing diabetes management, but they are very intimate and you don't want to be the diabetes police. So digging deeper without being the diabetes police means asking for permission instead of diving right in, asking for the person to set the stage or paint the picture, as Michelle was kind of talking about, instead of making assumptions. And finally, it means putting those behavior change and motivational interviewing principles to work instead of teaching and telling. Change or motivational interviewing resources provide desk cards, and these just have sample questions, and you can kind of see this Diabetes Canada version on the bottom here of sample questions. But I recently listened to a really lovely presentation by a dietitian named Razmi, and she provided some even more specific and diabetes focused questions that I really love. And some of these are, what, if anything, would you like me to know about your diabetes that I have not already asked? Do you have enough food to eat every day? And this kind of relates to the knowledge that a lot of low cost foods tend to be higher processed, higher glycemic index, so that might help provide some insight. Which foods have you recently eaten and what prompted you to eat them? One of my favorite questions is, which foods do you eat to be healthy? This is a great open-ended question. And finally, what do you think can be done, what caused this problem, and what do you think can be done to treat this problem? So really nice questions to kind of paint the picture and get that conversation on the table, hopefully getting the patient talking more than the provider talking. Look at the areas above the green bar here. So the green bar is the target range, and we see the snow-capped mountain peaks. So when we think about each 1% of time in range is 15 minutes of the day, think about how much we can improve this by chopping the tops off these mountains. So we know, and when you read Adam Brown's document, there are 42 factors that affect BG. So I don't want to simplify things by any means, but if we just talk about food and insulin for a minute, think about the insulin action profile of our available mealtime insulins. We know that insulin options are getting better and better, but still none are as fast as the response from a healthy pancreas. For most foods, and especially for foods with a rapid glycemic response, injecting insulin before eating, and sometimes a really good chunk of time before eating, is important to properly match timing to the insulin action. And the other thing is that you want to get the right amount, and this is likely a harder task, and one that is for a different talk entirely. This is a great article that I've linked at the end, so no need to try to read that small writing at the bottom, but it nicely illustrates some of the common sensor graph patterns and strategies to address them. So the scenario on the top left is the ideal 4-hour rolling molehill. It has a glycemic excursion that its peak doesn't rise above postprandial targets, and it resolves to pre-meal targets within 4 hours. This is perfect. No change is needed. B in the top right shows a postprandial excursion that rockets into a mountain peak above the post-meal target. And by 4 hours, though, the line is back to or close to pre-meal target. And this means that the amount of insulin was right, but the timing was off. So perhaps in this situation, something like a pre-bolus could be talked about. Giving insulin ahead of time can help knock the top off that mountain. C on the bottom left shows a postprandial rise with extended hyperglycemia. Pre-bolus and more insulin could be helpful here. Maybe trying one at a time might be good. And D is a funny scenario. It shows a peak excursion within target, but quickly dropping line that falls into hypoglycemia before 4 hours. And this could mean a few things. Perhaps it was a higher fat, high protein meal. Perhaps gastroparesis is at play. Perhaps there was a large pre-bolus that had too much lead time. So just interesting to talk about with your patients. And sometimes this visual tool can be really helpful. So rate of change arrows, I mentioned they're really powerful. They have a lot of insight and they're really useful for diabetes management decisions. Some folks will make adjustments using the trend arrows based on gut intuition, but this is really hard to communicate and really hard to replicate. Luckily, there are guidelines on how to adjust insulin based on rate of change arrows. So insulin corrections depend on the insulin sensitivity. And the first method, kind of in the middle there underneath the word units, is based on the ISF. So the person would choose a scale based on their ISF, and based on the arrow, they would add units directly to their correction dose that they've calculated based on their ISF. The next method under the millimoles per liter is actually to take a few steps back, and instead of adding units directly, they would, based on the arrows, they would add a value to their BG result or their sensor glucose, and then in turn use their ISF scale to calculate the correction. And if this seems really overwhelming, or if I'm talking about gibberish, each sensor company does have some of these guidelines on how to do this, but I find that they're very nicely cataloged on the Diabetes Educators of Calgary website. And so if you go to you just Google their website and go to sensors and adjusting based on arrows, it has the different company ones. And these are a Dexcom one, and it shows if the arrows are going down, how much to subtract, or if the arrows are going up, how much to add. So really helpful data there. I get really excited about diabetes technology. I love technology. I love graphs. I love talking about data. I love talking about food. I am, however, not the end user. If anybody's familiar with Michelle Sorensen, she did a really great talk recently that helped remind me that despite the awesome capabilities of diabetes tech, it also carries its own burden and can certainly contribute to diabetes distress. And it can do this through alarms and interruptions throughout the day, and maybe more importantly, throughout the night, placing more pressure for better results. We know that data can motivate, but it can also discourage, causing people to think even more about diabetes and management. Increased involvement from loved ones. So it's really important, if you're going to use any of those apps, to set expectations. So if you look at the texts here, which check-in would you rather prefer? You're low, I'm worried about you, answer me, with exclamation points and question marks. Or would you rather just have candy, thumbs up? If anybody ever texts with Anne McLaughlin, she has a really strong emoji game. Anyway, initial period of excitement is often seen in the first 6 to 12 months after starting on sensor tech, there's an initial period of excitement in the first bit, but then 6 to 12 months later, there's a marked increase in diabetes distress, and that's often seen through a lot of these factors. Other challenges certainly are cost. So these devices are not cheap, and not everybody has coverage. Skin irritation, which I'm going to talk about in a second, and unmet expectations. So sometimes people come into it thinking that this sensor tech is going to do stuff for them that isn't really realistic. Adhesive wipes and tapes can be really helpful if sensors are having difficulty staying put for their full wear time. Skin irritation. So skin irritation has been reported with all devices that attach to the skin. There's not one sensor that doesn't have perhaps some skin issues, and a patch test can be wise. Once you put a sensor on and it's itchy, you can't really take it off and adjust without ruining the sensor. So barrier products, anti-allergy products are helpful tools in this regard. Placement can play a big role in the tolerability and skin reactions. Some areas are certainly more prone to sensitivity, and some are more prone to sweat. And finally, the technique is also important. So ensuring proper insertion technique will help make the sensor accurate, but also just help with tolerability. Each of the companies that provide sensors have great handouts on skin considerations and troubleshooting, and you can find them on their websites, or again, the Diabetes Educators of Calgary. I'm humbled every day by the resilience and the effort and the perseverance of the folks that I have the privilege to talk to every day, and I'm always learning from them every day. So I just like to say that, and I just wanted to put a plug out there for realistic expectations. I don't know if anybody's ever used one of these soapboxes before, or know what they're for, but I remember being in my doctor's office as a new mom with my first baby and talking to my GP about sleep in babies, and he eagerly told me a story about a friend of his who solved his sleepless nights with one of these boxes. So to cope with chronic nightly feeding sessions, the sleep-deprived parents tied a soapbox like this inside the crib with a peanut butter sandwich in it. And the baby would wake up, grab the sandwich, eat it, and go back to bed. And that solved everything for them. But as a new mom, I was horrified in a really judgy way about this method. I was thinking about dental health and choking. But little did I know that kids in less than 2 years, and I would promptly lose all of my judgy ideas, because I realized that we're all coping in our best way. And this is my not so short story to say that people are not robots. We can't always follow or meet the black and white guidelines that are set. And sometimes folks are going to come into your office with a sensor on their breast, or they're going to come in with a DIY looped pump. And we have a duty to inform patients on best practice and discuss safety, certainly. But ultimately, we do have to meet folks where they're at and still support them with their diabetes management. So this is my last slide, just to recap. Diabetes technology and sensor technology specifically can be game-changing, but we still need to individualize our targets, find a sensor type that works for them, individualize our strategies. Some might want really simplistic approaches, and some might want to adjust based on arrows. Remember that this data is very intimate, and we want to be tender. And certainly keep on that discussion of diabetes distress and distress related to diabetes tech, because it certainly is a real concern. And resources are linked in this PowerPoint presentation, but if you wanted to just Google stuff, Diabetes Educators Calgary, diatribe.org. If you wanted to Google that consensus document, TIR Battolino 2019, Bright Spots and Landmines, and the rate of change arrows, with the 4 red boxes, if you just Google AGEN 2019 using rate of change, that will get you there. So if for some reason the links don't work, you should be able to access all of those resources just by Googling. Okay, so that's the end. I thank you very much. I hope that you found something useful in this presentation. And if
we do have time.
questions,
Thank
I'm
you
happy
so
to
much,
go there.
Lisa. That was fascinating to go through all of that information and see it laid so nicely and organized. And now my head feels a little bit more comfortable with some of that information that we look up. So we have one question in the question and answer. What difference is there with the Freestyle Libre 2 for children? And I think they were asking a question about the connection between aspirin and orange juice, perhaps with the
aspirin and
with the vitamin C.
Oh, vitamin C. So the vitamin C is levels at the RDA upper limit levels. So I don't, like, unless you have an orange juice that is supplemented with a lot of vitamin C and they're drinking it regularly, I don't know that it's going to have a big difference, but you certainly want to maybe check with the manufacturer. And ASA is at a, for analgesic purposes. So if you're using it at the, I think it's, I forget, like 850 milligrams or whatever you're using for pain relief, and if you're using it regularly, so it's not at the blood thinning
81 milligram
levels. Yeah, exactly. Sensor users, alternate sensor sites. How do you address this? Is this a concern? I mean, some folks are going to come in and you can say, oh, it's only indicated in this area. And but I think it's kind of important to keep Dr. Vallis's advice in mind when we talk about just where the patient is at. And certainly, you know, like if you are concerned about a site, if they do a finger stick and kind of do a bit of a comparison, that might help provide a bit of insight. But people are going to use the sites that they're going to use. I've seen them on forearms. I've seen them on breast tissue, on legs. And, you know, we have a duty to say these are the indicated sites. But people are going to do what they will.
And just to go back to that first one, the difference between the Freestyle Libre 2 for children, is there anything different in terms of that other than age group that it's useful or indicated for?
Is there?
I think with the Libre 2,
I understand the question. What's the difference between Freestyle Libre 2?
Children. I think with the Libre 2, there's an age, like you can use it with children, but with the Libre, the age is higher.
That's right. Yeah. So the age indications are different. So the age indications for the Libre 1 is 18 and older, and the age indications for Libre 2 is 4 and older.
And another comment we had just over in the chat, I did pick that one out. It's important to remember that sometimes the technology does not always match up. New phone and a company may not have updated apps. So we may not be able to get the apps if your phones are older. So that's certainly a very important thing. And I've been caught in that with some of the, it's like, oh, your phone's too old, so we can't use the phone as the app, but you'll have to use a reader or other way to get the information.
Yeah, and I mean, the challenge with the reader is that you can often upload it, but it does take a bit of technical expertise too, with drivers needing to be updated and that type of thing. And I've even seen somebody with a new phone that they bought that didn't have near field communication. So it wasn't old, it was just purchased, but it didn't have that feature. I don't know if it was just kind of a really base model phone. And so it couldn't be used either.
Certainly an important part. And usually if I have people that I'm helping them set up, make sure you bring your passwords for Google Play or your App Store with you so that we can get into those things. So having those little pointers for people along the way is important to make sure they have all of the tech bits of information. And I must say, I don't know about you, but I've certainly increased my tech savvy knowledge over the past year just because you're doing things by phone and trying to describe it as you can.
Totally. Any sites related to site reactions. So if you go on the Diabetes Calgary Educator or Diabetes Educators Calgary website, they do have a really nice CGM site. And so you can go to skin reactions, and they have cataloged all the different companies, because each of the companies has some troubleshooting documents for skin reactions or for adhesion, that type of thing. And so they're really nicely cataloged there, really nicely organized. I'm wondering if you have good success with the Freestyle Libre because multiple patients have a really big difference in the reading value concerning the amount of time. Yeah, and so certainly we talk about lag time when they're comparing a finger stick result to their sensor value. So we talk about that. And they might be having a site or a sensor that the time is really off, and I encourage them to maybe contact the company to troubleshoot some of those issues. Any sites related to site reaction? Oh, that's already been asked.
I just going to add a comment to that one with the site reaction. Be a site reaction, but I have a lady actually just last week, and she was having an issue with sensors sticking to her arms, but her stretch marks, she had them in areas of stretch marks, so that was sort of inhibiting the stretching. So that was an important piece to make sure that we had, you know, putting them in areas where she didn't have that type of skin that would maybe not make it so sticky. So it was a about location, and sometimes it is a bit of trial and error.
Yeah, absolutely.
Perfect. I think that closes out our questions for today. So thank you very much, Lisa, for sharing your wealth of knowledge, and a reminder to folks as well, the presentations are being recorded. The slides will be available post-conference as well. So I'm going to throw you into your lunch break. I wish I could say what we were having for lunch at the Delta at this point in person, but we're in the virtual world, so I'll leave you to your own devices for your noon hour. Don't forget to visit the exhibit hall, of course, get that scavenger hunt question Survey Monkey filled out so you can get your name in for the prize draw at the end of the day. And I will pass it over to you for your lunch break. We will begin again promptly at 1 o'clock. Erin Musgrave will be your moderator.